Hello and welcome. I am Megan Golden. I'm co-founder and co-director of Mission Cure, and I'm going to be the MC of this webinar. So first, thank you very much for attending. This is the first of what will be a series of webinars for patients and their families on pancreatitis. And there are almost 100 people registered, so we're very excited about that. Before we start, I need to let you know that this webinar is being recorded. It will be available and posted on the websites of Mission Cure, National Pancreas Foundation, and INSPIRE. And you have all joined in listen-only mode, so that means we can't hear you. If you have questions, and we hope you do, please type them into the question box on your webinar control panel. So let's get started. So here is the agenda. First, I'll tell you a little bit about Mission Cure, and Matt Alsanti will talk about the National Pancreas Foundation. And then we'll have a presentation on pediatric pancreatitis for about 40 minutes. After that, we'll have plenty of time for questions. And then Linda Martin, my colleague from Mission Cure, will tell you about some of our upcoming activities, and then we'll conclude the webinar. We plan to end at 2:30 p.m. Eastern in an hour and a half. So I will begin by telling you a little bit about Mission Cure. I was working for a nonprofit called the Institute for Child Success, leading a program that uses an innovative funding mechanism to increase funding for early childhood programs across the US. There's been a big movement around the world since about 2011 to test innovative financing for early childhood and other social programs. During this time, my younger brother Eric was diagnosed with chronic pancreatitis. And as we searched unsuccessfully for a treatment to relieve his pain, we realized that this same financing that I had been working on could be applied potentially to cure a disease. So we launched Mission Cure with seed support from the National Pancreas Foundation in 2017. And our mission is to develop effective therapies for chronic and recurrent acute pancreatitis within 10 years, demonstrating a new model for curing disease. So our approach has four main components. One is the financing is based on patient outcomes, not just based on what will make the most money in the market for the investors. Second, we have partnerships with impact investors. So these are people who want their money to make a positive impact on society, in addition to getting some financial returns. Third, we have active collaboration among stakeholders who don't usually work together. And then fourth, we use cost-effective methods to cure disease, which I'll give a very brief preview of in just a minute. So pancreatitis in children and adults is our first priority. Chronic pancreatitis affects about 150,000 people in the US and over 1 million people globally. And approximately 7,500 children in the US get acute or chronic pancreatitis. So I don't need to tell you how devastating this disease is for the people and the families affected. There's no approved therapy that will halt the disease, and yet our healthcare systems are spending billions of dollars per year on chronic pancreatitis. So that actually makes it a good candidate for this type of financing. So there's more on how the financing will work on our website, and we will actually have a subsequent webinar where we'll go into it in detail. But here's just a little preview of the strategies. The idea is that we will invest in a portfolio of strategies to substantially improve patient outcomes. And one of those strategies is testing already approved drugs that can move faster through the process because they've been approved for use in people. and that the leading scientists believe may help people with pancreatitis. And this will be done using the latest findings from gene sequencing of people with pancreatitis, and we'll have a separate webinar on that as well. We also have a patient advocacy and education program, and Linda Martin will tell you about this when she concludes the program. We've gotten tremendous support, not only from the National Pancreas Foundation, but really from the whole scientific community. So please feel free to contact me or Linda, and please sign up for our email list. And let us know if you're interested in helping or even some potentially investing in some of the projects that we are developing. So now I want to introduce Matt Alsanti, Executive Director of the National Pancreas Foundation. You may know him as the guy who dyes his hair purple every November. Matt came to the National Pancreas Foundation in 2013 after serving for 7 years as the executive director of the Sarcoma Foundation of America. And he's really grown NPF significantly and will now tell you about some of the foundation's activities. Matt?
Great. Thanks a lot for that, Megan, and welcome everyone. Thrilled to be a part of this meeting. I'm glad we could help to support it, and hope it's beneficial to you. And please follow up with us and let us know that the topics and information you'd like to hear more of in the future. To give what I'm going to do here today, just over a couple of minutes, is give everyone just a quick background on who the National Pancreas Foundation is, or NPF, just to let you know more about us and who we are. Our mission, the most important part of our mission is that first sentence. We're here to provide hope. And we do that for people who suffer from pancreas disease. And with saying that, it's mostly pancreatitis and pancreatic cancer. We're organ specific. So we help people with those diseases. We do that by funding cutting edge research. We do patient advocacy. We take care of educational events for both caregivers, for medical professionals, and for patients. So how do we do that? We have a few NPF programs. We fund research. It's really important in pancreas disease to fund research so we can find new treatments, ultimately so we can increase the quality of life. So the NPF does that by awarding grants for $50,000, and we funded 109 of them. That in itself is important, but what the whole purpose of our research program is to plant seeds. We sprinkled 109 seeds all around the country, and that research has led to millions and millions of dollars of additional research towards pancreas disease, to one day hopefully finding a cure, but in the meantime to really improve and increase the quality of life for patients dealing with pancreatitis or pancreatic cancer. One important aspect of the National Pancreas Foundation is recommending where patients go for treatment. And what we really think is important is to recommend places that have multidisciplinary care. And that's a big word, but it's an important word in that you just don't go see one medical professional and it's a one, they do all of everything. We developed an audited criteria that makes sure that the institutions that we recommend have the experienced gastroenterologists, the surgeons, the dietitians, psychosocial support, the pain support. All that information is available through our website. And just to let everyone on the call know, applications are continuing to come in, and the University of Iowa will be approved very soon and added to that. I just wanted to throw that out there on the call, but all that information is available on our website. Another important aspect of our website, there's a link, and it's pancreasfoundation.org, and that'll be up on a future slide. We have an online support group called the Pancreatitis Support Community. And this is a great place to go where you can ask questions, share information with other people who are battling any aspects of pancreatitis, whether it's pain, depression, pain for your treatments, and it's really designed to be a safe place. And it's monitored, so if things spiral a little bit out of control, as sometimes support communities can do, we'll get in there and clean it up a little bit. So it's a really safe space, and if you're interested, please check that out. The next couple slides are just a quick, if you haven't been to our website before, there's a lot of really good vetted, valuable information on there. That's just a screenshot of the top of our website, and you can see the patient information tab is highlighted. So you can see all of the different topics we have there about on different topics for the patients. We have a link to our research, to our various state chapters. I believe we're up to about 22 state chapters, so you can go to your state chapter page if you want to get more involved on the state level. And then there's a bunch of take actions, ways you can help and make a difference. When you scroll down our website, it goes to some of our featured programs. We have a national patient registry. We have something called the animated pancreas patient, which I'll go into more details in just a minute. Like I mentioned, we have our state chapters, our centers, a link right there to the support community. And then any patient educational events, you can click right on there, and that'll take you to anything that we have scheduled. I'm going to talk for a minute about our animated pancreas patient. This is a really great program. It's a standalone program where a link from our website will take you there. It has all these different aspects of pancreas disease. It has physician interviews. It has patient testimonials. There's an actual app for either Android or iPhones that you can go to. And the neat thing about the app is there's certain games on there. I tried to make it fun, and it's really educational, and it really gives you some interesting information. This slide just shows you more about the breadth of the information on there. Now you can see the one that says new. Our latest module is all about pancreatitis in kids and teens, so it's definitely tailored for that audience. The animation is at a certain level that kids and teens can watch it as well. And it's very thorough, but then the entire learning module packet can be really valuable to the parents and to the kids as well. It just goes into a little bit different take and a little bit more detail in those other modules. So I encourage you to check it out if you haven't already. And again, my name's Matt Alsanti. Please take a look at our website, pancreasfoundation.org. We're always looking for help and assistance if you want to be more active in your local community, or if you just want the latest and greatest information. There's a lot available on there. So thank you all for attending, and look forward to the next future modules.
Thanks, Matt. Now I would like to introduce our feature presentation. I'm pleased to introduce Dr. Aaliyah Uch, Professor of Pediatric Gastroenterology and Professor of Radiation Oncology at the University of Iowa. Dr. Uch is the one who 8 years ago, I think it was, said, we're seeing so many children suffering from pancreatitis, and we really don't know what this disease looks like in kids or how best to treat it. Let's do something about that. And she created a global consortium of centers treating pediatric pancreatitis and raised money for the research study that she's going to tell you about. And I should say that although people participating in research studies are really entitled to learn about the findings, presenting interim findings by live webinar is a very new thing, and we really appreciate Dr. Uch's willingness to be a pioneer in this area. So I now am turning the controls over to Dr. Uch.
Good afternoon, everybody. Thank you so much, Megan and Matt and Linda, for inviting me to participate in this webinar, one of its kind. It's really great honor to be here. And I know a lot of our INSPIRE families are participating today. Some of them are patients and parents that I have worked over the years. So I just want to say hi to them. I truly appreciate their dedication to the research study as we just look for more answers. I'm unable to advance my slide. Megan.
Yes, I think if you click on the presentation itself and then try to advance it. Yes.
Yay. Okay, it worked. Okay, thank you. So this is what I will talk about today. So I will tell you a little bit about pancreas and what it is and what it does and what pancreatitis is, and we have different types of pancreatitis and what causes it and how it happens and what is the mechanism and what workup we do if a child presents with pancreatitis and what treatments we have and how pancreatitis progresses and what new treatments are available and what's in the horizon. Okay, a little too fast, sorry. This is kind of, it's really have a mind of its own.
Okay, would you like me to advance the slides?
It kind of has a lag. Okay, so all right, maybe, but let's try this. Okay, sorry about that, a little glitch here. Okay, so what is pancreas and where it is and what it does? So pancreas is in the center of the abdomen and just behind the stomach. It's a little bit hidden, actually. It's a little hard to reach. Maybe that's the reason why we haven't learned a lot about it over the years, and it's hard to get to it, hard to study. It's a pretty unique organ. It's just right, if you look on the side over here, it opens up to the small intestine, a part of the small intestine called duodenum. It makes those pancreatic enzymes made by the acinar cells here at the bottom, which makes about 95% of the pancreas. So that is responsible of digesting the food before it is absorbing the intestine. And the duct cells that are responsible of transporting the enzyme into the intestine where it takes action. And also a very small portion of the pancreas, which is the islet cells. It takes probably only 2 or 3% of the pancreas, but it has a very important function of the sugar metabolism. So this is where you make your insulin producing cells, and that is why pancreas is very, very important. So I'll try to advance the slide now and see what happens. Yay. Okay, so what happens when pancreatitis happens and what causes it? So there's usually an insult of some sort to the acinar cell. That's the cell that makes those enzymes. And there's an increased calcium within the cell. This is an activation of the cell, and the enzymes that are produced within the cell that should be in an inactive state get activated, and then the cytokines are released, and there's inflammatory cell infiltration, the swelling, and then more inflammation, and inflammatory cells are pulled to the area that causes a significant amount of pain. And depending on the magnitude of the inflammation, the pancreatitis may be mild, moderate, severe, can involve just the pancreas, the organs surrounding the pancreas, or maybe other organs such as lungs and kidneys and the heart. And the patient may be very sick depending on how severe the process is. And eventually things cool down and inflammation goes away and the patient recovers. So this is the mechanism. And there's some debates about what happens exactly within the cell, whether it's the trypsin or enzymes or other factors, but this is basically it. So what we know about pediatric pancreatitis and what we knew before 2000 or within the 20th century is very little. So about 2 papers per year or 200 papers over 100 years. So our knowledge was pretty limited. So when that happens, of course, when the pediatricians don't know about a disease, we tend to go to the adult literature to understand what is going on, which is not always ideal. That changed with this paper. Again, we're looking at like only like 2002, not that a long time ago, 15 years ago, when one pediatrician in Dallas, that's UT Southwestern, just his observations saying that, you know, we're just starting to see a lot of kids with pancreatitis over just a matter of 5 years, anywhere from 5 a year to hundreds a year. And that kind of just raised awareness among the pediatric community, and that was also corroborated by others, and that almost parallel to the numbers of the tests ordered. So it wasn't that there was an increase of numbers of kids with pancreatitis, but people in the emergency room or in the pediatric offices were recognizing and ordering the tests to recognize and understand that, yes, the kids actually have pancreatitis. And I think a lot of us who treat these kids will see it maybe after second, third attack of pancreatitis as being the first, but actually those kids were having pancreatitis before. So our challenges are then, we're dealing with an illness that's not very common, and we don't have a lot of reports in the literature, so we don't have a lot of experience. As I said, then we go to the adult literature for the diagnosis and management, but the kids are not little adults, so we have some challenges there. And the risk factors are not the same because alcohol and smoking are listed as common risk factors in adults, which is not the case in pediatric population. And then because it's not a very common disease, you know, one site is going to see 10, 15 patients, and that's not going to create enough knowledge. So we need multiple centers to understand these diseases. And this is how INSPIRE study came about, and it really stands for International Study of Pediatric Pancreatitis in Search for a Cure. And we had initially 13 sites, and we really wanted to have interested people around the globe. That's why we're kind of just spread out around the globe here. And this was the largest cohort of well-defined children with acute, recurrent, and chronic pancreatitis. We had 565 kids, and some of the kids and the parents are attending this webinar. And we also collected DNA samples to look at the genetic material. So our goals with the study was to be able to create enough kids with this disease for us to better understand these diseases and create a network of sites to perform clinical studies. But our ultimate goal is to develop better therapies and to improve the lives of children and families with pancreatitis. So how we diagnose acute pancreatitis? So you need 2 out of 3 of the symptoms. One is a belly pain. And the other one, those 2 tests that I talked about, which is amylase and lipase, more than 3 times the upper limit of normal. And that's important because the normal limits change from lab to lab. And then an imaging study that shows that the pancreas is swollen. And here on the right side, you see an ultrasound image that shows like almost like a sausage shape pancreas. My screen is still touchy, so I apologize about that. So the causes of acute pancreatitis in children can be very broad. I think in this study you see that the obstructive, which is gallstones, things, you know, kind of blocking the pathways emptying from the pancreas into the intestine, usually a most common cause. Medications, some medications will make the kids prone to have pancreatitis. Idiopathic, that's when we found absolutely no reasons. That makes about 20 to 30%. Systemic illness, if a child has, let's say, kidney failure or another systemic disease, the pancreas may also be inflamed. Trauma, blunt trauma to the abdomen. We see this sometimes with the bicycle handle injuries. Viral illnesses, we see that as well. Metabolic, like changes in the calcium electrolyte, sometimes we see that. ERCP, about 7% of the time, the test that done to relieve the obstruction in the pancreatic duct can by itself cause pancreatitis. Other things like genetic and alcohol, those are for just one attack is uncommon. Acute recurrent pancreatitis, when things happen more than one time, and we have some definition. If you have 2 bouts of pancreatitis, but it should not be the same attack ongoing, it should be an interval between the two. We say about at least a month, or the patient should be completely recovered. The chronic is when there is irreversible changes or the scar tissue developed in the pancreas. And this is only one of them needed to make the diagnosis, is having either belly pain and the changes in the pancreas showing permanent damage, such as stones blocking the pancreatic duct. Pancreatic duct is narrow or dilated. Pancreas becoming very, very small or stiff, scarred with calcifications. Or the pancreas lost this acinar cell that makes the pancreatic enzyme. We call it exocrine pancreatic insufficiency. So the patients are unable to digest the food, such as diarrhea or oily stools. Patients may be prone to fat-soluble vitamin deficiency, listed here, A, D, and K. But then plus the imaging findings. Or if the patient have lost the ability to regulate the blood sugar, such as in diabetes, and show already changes consistent with permanent damage. So you need one of them to make the diagnosis of chronic pancreatitis. Here are some of the imaging changes that I referred in my previous slide. This is an ERCP image of a child with chronic pancreatitis, and here you see the scope that is placed for the ERCP, and then the catheter that's advanced into the pancreatic duct. This black-looking thing is shadow, is actually a large pancreatic duct stone. This kid has multiple stones. The pancreatic duct is pretty enlarged, dilated. So those are some of the chronic changes that we see with chronic pancreatitis. What causes that in kids? What causes are the acute recurrent and chronic pancreatitis? That's a little different than what I told you about acute pancreatitis. What we're finding in pediatrics, that a lot of times the most common reason is the genetic mutations in certain genes, and more so with chronic than acute recurrent. And the second most common is the obstructive, something blocking. We found pancreas divisum, which is an anomaly that I will get back to it later. Some medication usage associated with acute recurrent pancreatitis, some seizure medications or cancer medications. Lipids, mostly triglycerides with acute recurrence, we have seen. Autoimmune pancreatitis, alcohol or smoking, those are very rare. Continuing on the causes of acute recurrent and chronic pancreatitis in a little bit more detail, the genetic conditions, I'm listing the mutations here. I will talk a little bit in the next slide. Obstructions, gallstones is one. I mean, the idea is that once the gallstones are removed, this problem is going to go away unless there's some remaining stones or there are other reasons. Pancreas divisum, here, in the womb, the pancreatic duct, the ventral and the dorsal, the two ducts will connect together, making this kind of Y shape. On the right side, you see the normal pancreas. If this fails to occur, the pancreas divisum or divided duct system happens, and then the main pancreatic duct will drain through this very small opening. Whether this causes pancreatitis, it's debatable. Metabolic abnormalities, increased lipids and triglycerides, we always check for those. Calcium, kidney failure, metabolic diseases, rare in general in pediatrics. Toxic causes, I mean, those are medication, smoking, and alcohol. Again, not very common. And autoimmune pancreatitis, again, when the body kind of attacks itself, that's also uncommon. The genetics is something that we see very commonly, and some of those mutations you will hear repeatedly. In the center of this is the trypsin, which is an enzyme that is responsible of digesting the proteins in the diet. And the PRSS1 or the trypsinogen is the inactive form. If there are mutations within that gene, this will be activated prematurely, or if it's activated, there will be problems in kind of just turning it off. So mutations within the trypsin is one reason. And there are other genes within that pathway, such as chymotrypsin C or SPINK1, which work on turning down the activated trypsin. CFTR, which is the gene responsible for cystic fibrosis. There are some mutations that don't cause cystic fibrosis, but some changes in the function of that gene that may be responsible of recurrent attacks. And there are some other genes, not necessarily in the trypsin pathway, but make the pancreas prone to have multiple attacks. So how does this happen? So this is a normal pancreas, and in about 1 to 10,000 kids, they get an attack. So that's an unlucky event, and we talked about multiple reasons that can happen. And hopefully this will not happen again. And but in 15 to 35% of kids, there will be a reason for that to turn into acute recurrent pancreatitis. And again, in a small subset, which again, those numbers are not, I'm not reporting this to large, wide epidemiology studies, but about 2 in 100,000 with chronic pancreatitis. So what makes the kids prone from normal, a pancreas to become irritated and inflamed and have acute pancreatitis? We have some understanding about that. But what makes them prone from acute to acute recurrent? We have some understanding about that. And what makes them prone to have multiple attacks? And then will that make them prone to have scar in their pancreas to chronic pancreatitis? And how fast that occurs? Those are still questions that are ongoing. So if someone has multiple attacks, or we suspect chronic pancreatitis, there's a workup that we do. I mean, we want to look for the causes. We need to understand what causes pancreatitis, and then there could be some treatments, some hope for potential therapies, and liver tests that we do that listed here. I mean, it may be associated with obstruction within the bile duct, since everything is related with the bile duct and the pancreatic duct. So this is something that we do. Fasting lipids and triglycerides, if that is elevated, there are very rare metabolic diseases, and one of them is FCS, or familial chylomicronemia syndrome. There's a drug called volanesorsen right now for ApoC3. So that's, again, a very rare disease, and the drug is investigational. They're going through FDA approval. So we look for causes, make the diagnosis, and if there is a treatment available, there's hope. Fasting blood sugar, diabetes. Diabetes can cause pancreatitis and vice versa, so that's something that we do. Genetic mutations, we're trying to understand the root cause. Serum calcium, again, that can cause pancreatitis. It's very rare. We've been looking this for some time. I haven't found one, but that could be possible. Sweat chloride, rarely. Cystic fibrosis, a very late presentation, can present with pancreatitis. So that changes really the treatment and how we follow those kids. So that needs to be done. Celiac disease, certainly there is a connection between celiac disease and pancreatitis, so that's something that we do. Autoimmune pancreatitis, there's some lab work and imaging. It's not a very clear cut in pancreatitis, but this is something we also look for. Abdominal ultrasound, this is done mainly looking for gallstones and obstruction. And MRCP, again, is a very good test for chronic pancreatitis and obstruction. And ERCP, we don't do this for diagnostic purposes. We do this if we're looking to intervene. Let's say there's an obstruction in the ducts. And EUS is done with a handful of people, again, for the diagnosis of chronic pancreatitis, for interventions. And I don't want to give you the impression that I do this on each and everybody, but I think it has to be tailored for patient to patient. The screening, looking for complications, especially for chronic pancreatitis, if the pancreas has lost the ability to absorb the nutrients as fat-soluble vitamins that we look here. Fecal elastase, it's a pancreatic enzyme. We look in the stool. Tells me about the ability of the pancreas to digest the nutrients. Fasting blood sugar and hemoglobin A1C, again, this is for diabetes. DEXA scan, no pediatric data about this, but there's more in adult data that patients with chronic pancreatitis may be prone to weak bones, osteoporosis. This is something that we started doing. So what is the burden of disease? And this is a disease that kind of just flew under the radar for a lot of people, providers and insurance companies and NIH and research community for so long. But what we're finding, it's a great impact for patients and families. And here we looked at the amount of pain, emergency room visits and hospitalizations, and days of school missed, and the types of therapies that they get, which is quite significant. But once the kid developed the chronic pancreatitis, those increase significantly. Almost 90% of our patients have pain within the last year, and kids with acute recurrent pancreatitis, the pain is intermittent with the attacks. The chronic pancreatitis is more impactful. Emergency room visits is much higher with chronic pancreatitis, so is hospitalizations and treatments. And the days of school missed, again, quite significant. 2 days per month for chronic pancreatitis. About the pain in children, I already mentioned this, that there's some degree of pain in our group, and 38% have some level of constant pain, so they hurt on a daily basis, and 15% take daily or weekly narcotics. And chronic pain and daily narcotic use correlate with the number of emergency room visits, hospitalizations, and missed school days. So this is something that we're working on in our data right now, and not a surprise that when you're in pain, that affects what you do on a day-by-day basis. So how we treat, when someone has an acute attack, we rest the pancreas because pancreas will get stimulated and angry and inflamed when someone eats. But we also advocate for early feeding if the patient is tolerating feedings otherwise. Pain medications, including Tylenol, NSAIDs, So non-narcotic choices if possible, but the pain is quite severe, so we do narcotics as well in the emergency room, in the hospital, or at home. IV fluids, early hydration is important. Pancreas is very sensitive to dehydration, and nutrition, again, as I mentioned, we start as early as possible as the patient is able to tolerate the food and not nauseous, and advance as early as possible. And then we treat the underlying problem. Regulation of diabetes can certainly lead to recurrent attacks, so that's one thing. The treatment of lipid problems, I mean, I talked about this treatment, the FCS or volanesorsen. Again, this is a very uncommon disease, and the triglycerides would be in the thousands. So it's not a very easy thing to miss, and that this is not currently FDA approved. It's more investigational, but they're working on it. The treatment of celiac disease, if that's the reason, if there are gallstones or any other obstructive reasons, you take care of that. Treatment of high calcium, also I haven't really found one single patient yet. Treatment of cystic fibrosis, which requires a referral to a cystic fibrosis center, and the steroids if autoimmune pancreatitis is present. And I think the patient has, I mean, I tell the families that, you know, it's important to take good care of yourself, a good, well-balanced nutrition, and maintain healthy weight. There is some literature about obesity causing severe, I mean, in adults for sure, and more in common in pediatric pancreatitis, that obesity causes severe acute pancreatitis. If that's the case, whether it increases number of acute recurrent pancreatitis attacks, we do not know, but certainly maintaining a healthy weight, live a healthy life, no smoking, no alcohol. And there are some medications that can trigger pancreatitis, as I mentioned before, so it would be good to be aware. Some research that just came out this year, and this is really something for the future, but something to think about, is can we prevent the attacks in a subset of patients? So there is a drug therapy for patients with cystic fibrosis called ivacaftor. This is only for a very small subset. Maybe 4% of all cystic fibrosis patients have this kind of mutation. And what they've done, they went to their database. It's a large database of Cystic Fibrosis Foundation, and they found really just 6 patients, pediatric and adult, with these mutations. And then they looked to see, and pancreatitis, and then they looked to see how they did when they were on this drug called ivacaftor or Kalydeco. So those patients were having, so going back, they were having multiple attacks, like anywhere from 1 to 5 in a year, opioid use and multiple hospitalizations. So this is a 12-month data. So within the first 3 months, the pancreatitis attacks went from 1 to 5 to 0 and remained that way. Opioid use also went down significantly, except one patient, and maybe this patient number 5, but I'm not sure, not enough data. And hospitalization data also went down significantly. So this is a retrospective data and a very small subset, but it's encouraging for some prospective studies. So could the medications used for cystic fibrosis, if there's an underlying mutation, for some of our kids who have that kind of mutation, this is something that could be in the horizon. ERCP, endoscopic therapy, we have this study where we looked at the number of endoscopies done in our INSPIRE population, which is quite significant, especially if a kid has chronic pancreatitis. And what we found that it's helpful if the duct is blocked with stones. How about pain management? Pain is very complex with many factors involved. I mean, there is the obstruction problem. I mean, I showed you an image where the pancreatic duct was blocked with stones. So obstruction is one. So relieving the obstruction can be helpful with the endoscopy or the surgery. And then there's also the wiring problem that happens over time as the pancreas becomes repetitively inflamed with the scar tissue, that the nerves also get inflamed. And then there's the central sensitization, not only the nerves, but the spinal cord and the brain pathways also get inflamed. So that could be one reason why even taking out the pancreas may not cure the pain, because that's the phantom pain. So early and effective pain management is important here, and that will have long-lasting beneficial effects, and it has to be tailored for the child. There are several medication approaches, Tylenol, ibuprofen, NSAIDs. It's good to start with non-narcotics. If you have to use the narcotics, try to combine with non-opioids. And there are other medications listed here, gabapentin, pregabalin, low-dose antidepressants. Those really are geared to the nerve type pain or the neuropathic pain. Pregabalin is Lyrica, gabapentin is Neurontin. That's geared to the neuropathic or nerve kind of pain, and not much written about pancreatitis and almost nothing about pediatric pancreatitis. Stone removal, I mean, if that's due to the stones kind of blocking the duct, that could certainly help with the pain relief. And there are non-medication choices for pain management. And again, not much done or written about that, but that's really when you change the wiring before everything gets activated, such as the cognitive behavioral therapy, massage, yoga, TENS, acupuncture, and things. That is not fully explored for chronic pain management in pancreatitis. Going on the medical treatment, vitamin supplements, if deficient, that's what we know at this point. The antioxidant, which involves a cocktail of antioxidant vitamins and the minerals. There's some studies from India that looked into this, but we have no data in children. It's controversial. I mean, in adults, there are data that support this. There are data that don't support it, and there are no products here in the United States. The pancreatic enzymes, the idea is to kind of just put the pancreas at rest. Again, that is no proven value at this point. Insulin, if the patient has diabetes. Surgery is done really to relieve the obstruction. For gallbladder removal, if the patient has gallstones and causing symptoms or blockage. Pancreas surgeries, this is again if the patient has multiple stones in the duct, some maybe not even reachable with the endoscopy. And the downside is it reduces the yield for total pancreatectomy and islet autotransplantation. And of course the TPIAT. TPIAT is done in increasing numbers. There are more centers doing this. University of Minnesota started this, I want to say, about 35 or so years ago, and they have done most of the studies, but there are probably 10, 15 sites are doing this now. There is an NIH study called POST study looking into the ideal timing of the TPIAT and what kind of patients would benefit from it. So basically what you do, you're taking out a pancreas that's damaged, that's fibrotic. So the idea is just taking out an organ that's diseased, causing pain, and then just, but you don't want to remove the islet cells that are doing the glucose regulation. So the pancreas is taken out, the islets are harvested and injected back into the portal vein, where like you see in the C that they take residence over time and start working. And then there are, as this is being done in the islet lab, the surgeon does anastomosis, just take out the spleen, take out the gallbladder, take out the appendix, and then just connects everything together. The anastomoses are done. So who should undergo this if failed all the other therapies, medical, endoscopic therapies, and someone who has chronic unrelenting pain, significantly impaired quality of life. But there's a trade-off for pain. I mean, you lose all your pancreatic acinar cells, so the patient is going to end up using pancreatic enzymes for the rest of his or her life. The insulin independence is not perfect, so that could be another one. The kids do very well with weaning pain medications and insulin, but that's not 100%. That's about 60% within, I think, a year or two. And the long-term data is not what we have. So for pediatrics, it's significant because the long-term data is not beyond 10. Even I think their case report, it doesn't go beyond 15 or 16. So coming to the INSPIRE 2 study, which is the study we have right now, we completed our 21 study, which was really building the database for us. The INSPIRE 2 is a larger study, and it's called, it's part of this CPDPC consortium called Consortium for the Study of Chronic Pancreatitis, Diabetes, and Pancreatic Cancer. So in this one, I was not the coordinating center. MD Anderson is the coordinating and data management center. There are 9 other adult centers associated with this. And we're the pediatric site, we're the lead site, and there are 21 satellites and 4 international sites associated with us. Our study design is very similar to what we've done with INSPIRE 1. So we plan to enroll 860 kids, all pediatric age group. We take only acute, recurrent, or chronic pancreatitis. The study involves completing questionnaires about pancreatitis attacks and treatment, and how this affects their life and family functioning. And we collect a DNA sample to look for genes that are not clinically identifiable. And those are our sites, and I think we're up to 182 right now since we started enrolling in July 2017. It says 165 here, but that was probably a couple of weeks ago when this was prepared. What we have done, I think the INSPIRE 1 was, I mean, we really thought about this in 2009, and we applied for funding in 2011. 2012 is when we got our first funding. So that was the first NIH-funded study in pediatric pancreatitis ever. And it was the first definition of pancreatitis in children because we needed to even, understand how this is even defined before we could start understanding. So the largest group of kids with acute recurrent chronic pancreatitis was described by our group. And then we also described that the kids with acute recurrent and chronic pancreatitis suffer from gene mutations and changes in their pancreas and not other things that, that are seen with adults. And that's very unique compared to adults. And kids are not little adults. And we reported that children with acute recurrent and chronic pancreatitis have significant disease burden, as I showed you earlier, and the burden increases significantly once they have chronic pancreatitis. Some gene mutations are risk factors for early onset disease, early chronic pancreatitis, or rapid progression to chronic pancreatitis. We defined the autoimmune pancreatitis, which was not defined in pediatric age group before, and also developed the diagnostic guidelines for the diagnosis of acute recurrent and chronic pancreatitis. So our current goal with this INSPIRE 2 study is, we would like to continue building the cohort, which is a longitudinal and prospective observational study. And our goal is to collect the information for us to predict the course and eventually design the treatments. Looking into the future, I mean, can we predict the kids at high risk for chronic pancreatitis, chronic pain, poor quality of life, at disease onset? I mean, if I see a kid in the clinic for the first time presenting with the first attack of acute pancreatitis or the second one, acute recurrent pancreatitis, what kind of things I can predict about their life into the future, the chance of chronic pain, chronic pancreatitis, their quality of life. I mean, what's going to happen when they're 20, 30, 40 years of age, and what treatments are available, and what should they choose for the right treatment, and how can we prevent long-term complications. And some of them, as you all know, are pretty devastating. I mean, chronic pain, multiple attacks, emergency room visits, hospitalizations, surgeries, and diabetes, pancreatic insufficiency. And I mean, right now the TPIAT seems to be the treatment of choice for kids who have unrelenting pain and poor quality of life. But if so, who's the right patient, and what is the timing for TPIAT? How can we predict this? And what to expect long term? I mean, the TPIAT is, you know, our long-term outcomes 10, 15 years, but, you know, the pediatric age group goes much longer than that. And would the islet survive? What's going to happen to the liver that accepts the islets? I mean, there are a lot of unknown questions. So that's pretty much like looking into the crystal ball. What's going to happen to those kids as they grow up? Plans for the future, we would like to be able to offer more treatments. And one of the things that we were excited about is this ivacaftor CFTR modulator treatment. And there's a pilot that I know one of the PIs at the Toronto was planning, but this is a very premature at this point. Some of the kids have CFTR mutations and they have acute recurrent pancreatitis. And which ones would qualify with what kind of mutations? Because CFTR mutations, I mean, there are 2,000 of them. And she's trying to develop a way to predict the patients who would benefit, who show the dysfunction in this CFTR pathway. So if we're successful, we may be looking into expanding this to the INSPIRE population. We have a pain management study that we're working on. This is a grant application that is currently being evaluated by NIH because we're looking into non-medication, non-opioid approaches to pain and pain-related disability, because this is something that significantly affects our population. This has not been done in pediatrics and not even in adults, actually. This is successfully done, cognitive behavioral therapy for chronic pain and pain-related issues in other chronic pain populations, including chronic headaches, irritable bowel syndrome, abdominal pain. So we're thinking this is potentially a way for our kids and, you know, our patient population where maybe we can, you know, affect some of those wiring and some of the pain-related outcomes before they settle in. So we have planned this study with 130 children, either on the cognitive behavioral therapy or the control cohort, and then the study is going to go on for about 6 weeks, and then we will look at the outcomes. And the nice thing about this is all a web-based therapy done with a collaborator of mine who has developed this web-based cognitive behavioral therapy, Dr. Palermo, in Seattle. So we're hoping this will make a difference in the pain response in kids affected by this disease. And if we see a response, we would love to see if, like, how can we predict the response? Will it sustain? Which kids will benefit from this? Because we would love to be able to offer treatment options other than what is currently available. There's a lot of enthusiasm going on about offering treatment for acute, recurrent, and chronic pancreatitis in the scientific community and FDA and researchers and clinicians and patients. So I'm co-chairing this NIH symposium that's going to take place in Pittsburgh in July 2018. And the main goal of this is accelerating the drug delivery for acute and chronic pancreatitis. So we all realize, and most importantly, I think the NIH and FDA is completely supportive of this, that there are not enough treatments for pancreatitis for pediatric or adult population. So we will have this one-day meeting, and there's working groups for acute, recurrent, and chronic pancreatitis, really working on what do we need to do to accelerate the research and offer treatments really to become a reality for our patients. So it's not going to be tomorrow, but hopefully, I mean, there's a clear interest for this to happen in the near future. Okay, so in summary, there has been an increased understanding of pancreatic disease in children, but this is only for the last decade. And pancreatitis involves all aspects of life. It's general health, it's the nutrition, it's the GI issues, pain and quality of life, emotional and social and psychological issues, school and academic life, and family function. So it's a very involved and impactful disease. We have made a lot of progress this last decade. Still, we have a long way to go, so please stay tuned. Having trouble advancing again. I think I'm stuck. No, that's not what I want.
There we go. I just...
I think I missed one slide, no?
Okay, let's see. Nope.
Okay, well, that's the INSPIRE members. I would like to thank my collaborators and listed on the study. But most importantly, I would like to thank the families and patients for their unwavering support of our study. Without their support, the study that I presented to you could not be possible. Thank you for inspiring us every day. I'll be happy to take questions. Terrific. Sorry, this has been a little weird with all the advancement.
Thank you very much, Dr. Uch. And I encourage everybody to type any questions you have into the question box. We'll give that a try to begin with. We also could try to unmute everybody at the risk that we might have some background noise. While you're thinking of your questions, I want to draw your attention to handouts on your control panel. And let's see, I'm going to click on this handout that we have included. So it's on your GoToWebinar panel. You'll see a line labeled handouts. And if you click on that, you can download this handout, which is the recently published, just like literally in the last month or so, European evidence-based guidelines for the management of pediatric pancreatitis. So the leading experts in the world, including Dr. Uch, put these guidelines together through a formal process, and they represent the consensus on what the research shows at this point and its implications for treatment. And there also are some new guidelines for chronic pancreatitis pain, not specific to children, it's for adults, but that's also something that is out there. I have one question, and then Aaliyah, I will also ask you if you have any further comments on these evidence-based guidelines. One question is there any evidence that a low-fat diet helps kids with genetically based pancreatitis, acute or chronic?
Thank you for the question. So I think it is a very common practice that the children with pancreatitis, either after an acute attack, acute recurrent or chronic pancreatitis, are placed on a low-fat diet. And if you look into the research to back that up, the research that supports that is not very strong. It is pretty much based, my impression, based on the center experience and patient experiences, and varies from site to site. If a patient, complains of increased amount of pain, increased amount of discomfort after consumption of a certain amount of food that has increased amount of fat, that could be a reason to limit the amount of fat. But in terms of looking into the literature, there is not a lot of good research to back that up.
Thank you. We have several questions here. Next one is, can you talk more about enzyme therapy and if it is effective?
Well, enzyme therapy is very effective if someone has pancreatic insufficiency. So if the chronic pancreatitis settled in and the pancreas is not making enough enzymes, pancreatic enzymes are very efficient in helping with the digestion and the symptoms associated with the digestion. Now, when it comes using the pancreatic enzymes to kind of just create that feedback loop, so the pancreas goes into some sort of a rest, if you will, kind of feedback loop that the pancreas is not stimulated, so is not irritated to cause pain. That is mostly from adults. Enzymes being used for chronic pancreatitis pain. We don't have any evidence in children. The enzymes used for suppression of further attacks, there's really not much, nothing really in the literature about enzymes being used for a recurrence of pancreatitis attacks.
Thank you. I think you'll like this question. What type of physical commitment would participation in the study entail? I'm 2 hours from one of the participating sites, but would love to help advance research.
Oh, thank you very much for that. I think, it would be good for, getting in touch and be seen. There is a physical examination and a blood sample drawn, so that's pretty much the physical presence that is required. A physical examination and a blood draw, and then that's a baseline visit, and then and access to the medical records, and then annual visits.
Thank you. The next question. My son's pancreatitis is caused by genetic mutation. Within the last year, he's been diagnosed with type 1 diabetes. Have you seen episodes of pancreatitis decrease after a diagnosis like this?
Oh, that's a very interesting question. Of course, I have no way of knowing the exact situation of your child's particular situation, and it's hard for me to comment on it. The type of the diabetes seen with chronic, the type of diabetes seen with chronic pancreatitis is what we call type 3C. So you make enough insulin in the pancreas, but for some reason you're not secreting into the bloodstream. And type 1 diabetes and pancreatitis also have a connection, is that patients with pancreatitis and high blood sugar can have recurrent attacks. In terms of, is the question the pancreatitis decreasing or the diabetes decreasing? Pancreatitis decreasing after type 1?
Yes, it is. It is.
Yeah. Yeah, I mean, I think I would probably be, I mean, is it a type 1 or another form?
You know, sorry.
I mean, in our INSPIRE population, I mean, a lot of the pancreatitis, a lot of the diabetes that we saw was not type 3C, was type 1. I mean, the pancreatitis attacks, if it's acute recurrent, I do not anticipate that it will decrease until, you know, you lose all your acinar cells. And then, you know, chronic pancreatitis kind of pain is a whole different story, because, you know, you may have wiring issues and nerve related issues. So it's a tough question to answer.
Somehow I don't think that was the response she was looking for, though.
Okay.
So there's quite a lot of questions. So maybe we'll see if you can try to respond pretty quickly.
Okay.
Why are the use of antioxidants in genetic pancreatitis in children controversial? You mentioned that on one of your slides.
We have no data. In adults, it's controversial because one study supports it's for pain only. One study says that the pain gets better with antioxidants. One study says that pain does not get better.
Okay. Is it possible that anxiety or stress could trigger an acute attack?
No data on that that I can tell you. And you know, sometimes I hear that it's stressful situation. My patients report to me that I mean, there's higher likelihood for an attack, but I have no data to prove it.
Okay. And what is your view on any correlation between children with chronic pancreatitis and severe constipation?
Someone asked me that too. You know, I think a lot of times those kids are first diagnosed with other GI symptoms like reflux and constipation and treated for it, and then later diagnosed with pancreatitis. In terms of I mean, constipation being a manifestation, I mean, there's really no data. I mean, if they're using I mean, narcotic medication, that can cause constipation.
Thank you. And I know it's frustrating that there's not data on a lot of things, but that's because the data is you know, being collected now, and in this area there's, as in other parts of medical research, there really is kind of an exponential growth of data available to learn about these things, and our goal at Mission Cure is to keep this kind of at the top of the priority list so that we're learning more about the genomics and other aspects of the disease as quickly as possible. When is the best time to take enzymes? Many of our parents have heard various answers from before the meal, during, and after the meal.
Right with the meal is the best time, and some would advocate right in the middle. You should take it with the meal.
Where's the article you mentioned regarding pancreatitis pain treatments? I will see if I can send that out with the follow-up email, and if not, we will post it on the Mission Cure website. Are there many children with feeding tubes that experience recurrent pancreatitis?
Feeding tubes causing pancreatitis?
No, children with feeding tubes that experience recurrent pancreatitis.
As the sole cause?
The question didn't say anything about the cause. It just said that they experience it after they have the feeding tube.
No.
Is there any data showing negative impacts from long-term use of pancreatic enzymes?
Long-term negative impact of pancreatic enzymes on the patients?
Yes.
No, the only data that we have is from very early, this is now almost 25 years old data. High doses of pancreatic enzymes causing colonic strictures in patients with cystic fibrosis. But, that's really with high doses, but no long-term side effects.
Okay. Let's see. One more pancreatic enzyme question. My daughter has been diagnosed with pancreas divisum and has pancreatic insufficiency, taking Creon daily. Are there any other options, or will she need to do this for the rest of her life?
It's hard for me to comment on a particular condition, but if there is pancreatic insufficiency, and it's once the disease progressed to a point that the pancreatic acinar cells are lost, it's got to a irreversible point. It's a lifelong use of the pancreatic enzymes.
Are there any studies of ways to impact the pancreas to block the overproduction of trypsin to reduce pancreatitis attacks? Good question.
That's a very good question. I wish I had an answer for that. I think that's a research question for the future.
Well, I can actually make a comment. This is Megan Golden from Mission Cure. So one of the things that we did when we got started at Mission Cure was make a big chart of all of the therapies that are in development or have had some positive lab work done for chronic pancreatitis, as well as already approved drugs that there's a scientific basis to believe that they could make an impact. And that table is organized by what they call the type of target. So you asked about one of them around the production of trypsin. And so there's some list of potential therapies that could impact production of trypsin, or others that might address genetic diseases. And I think that the reaction when showing it to the scientists has been fairly positive, in that there's already quite a lot of things that have had some work done, that there's some reason to believe that they really could make a difference. And so what we're trying to do at Mission Cure is figure out the most efficient way to take all of these that are already on the list of potentially promising therapies and move them as quickly and efficiently as possible through the process of preclinical testing in the lab, and if warranted, into clinical trials where we can see if they can help people. There's another piece. We need to keep on discovering new therapies, but there's also quite a bit out there that we should kind of push through the process so we can get them to patients if they do work. And let's see, we are going to have to turn it over to Linda Martin. Let me just take a quick, here's a question. Can an attack be occurring even when the lipase test returns low? And what is the normal range?
Normal range differs from lab to lab. It's really, what's important is more than 3 times the upper limit of normal. So what happens in patients with chronic pancreatitis, if the amount of acinar cell lost so that they're not making enough enzymes. So the lipase values may not be high enough. And then the pattern of the pain also may be changing to more like a chronic pain that, with some acute changes here and there. And, we're looking into more like a chronic pancreatitis at that point.
Okay. We do have a few more questions, and we at Mission Cure will try to get the remaining questions answered after the webinar, if at all possible. And to answer one of those questions, yes, the recording of the webinar will be available. It will go out, I believe, in the email to everybody, as well as be posted on our websites. So now I would like to, so thank you very much, Dr. Uchin. I would like to now turn it over to my colleague, Linda Martin.
Thank you, Megan. And I would like to add my thanks to all of you for taking the time from your busy days to join us on this webinar today. And thank you, Dr. Uch, for sharing the findings of the INSPIRE study so far. As you were talking, it really struck me how important this study is, and not only to the children who are suffering with this disease and their parents, and not only to the medical community, but to the pancreatitis community as a whole. This really struck me as a landmark study that's shining a light on some of the underlying causes of pancreatitis, and this new information will hopefully help doctors with diagnosis and treatment decisions, but especially guide researchers to study these important areas. And also the upcoming working group meetings this summer in Pittsburgh to accelerate the drug delivery pipeline for pancreatitis. I think that is really exciting and promising. But one of the things I think is the most important about this study, Dr. Uch, is that you did it, that it happened, and now you're sharing the information and the data you gathered. And this is huge. Pancreatitis patients, both children and adults, often feel completely alone and completely abandoned by the medical community. I have found it's all too common to talk to a patient and learn that they thought they were the only one with this disease, and they hadn't met another single person going through what they're going through. It's often hard to find the right care, to find a knowledgeable and sympathetic doctor. Treatments have been ineffective or just plain wrong. And obviously there's no cure. Your study and your willingness to share the results are so important. So again, thank you, Dr. Uch, for participating in our first webinar. I really appreciate all the information you've shared. Okay, before we wrap up and sort of continuing on the topic of sharing new information, as Megan said at the beginning of this webinar, I'd like to take a few minutes to tell you about Mission Cure's new pancreatitis patient awareness, advocacy, and education programs. And I'm very excited to share our plans with you today. First, to introduce myself, I am the mom of an adult daughter who was diagnosed with chronic pancreatitis about a year ago, after quite a long time of searching for a correct diagnosis. Watching my daughter Amy, even though she's an adult, was beyond difficult, as she lost well over 50 pounds and spent every day in excruciating pain. She could keep virtually nothing down, and no one could figure out what was wrong. I, as her mom, was terrified. Eventually, one doctor said it looked like pancreatitis, and when Amy asked about treatment, she was told, just stop drinking. Well, as an adult, Amy had drinks occasionally and socially, but she was not a drinker and had been sick for so long she had not been drinking at all for months. The answer the doctor gave about just stop drinking just made no sense to me. So, as many of you have done, and as a mom, I thought, okay, there's something I can do. I'm going to take care of this. I'm going to fix it. Someone must have the answers. Someone must know the secret that cures this thing, whatever this is, whatever pancreatitis means. I started searching, and in my mind, I was searching for the thing that would save my daughter's life. Amy and I both started the search, going online, making tons of calls, specialist appointments, weeks of tests. Eventually, we got a diagnosis, chronic pancreatitis. At least we knew what we were dealing with. Well, sort of. But the journey is ongoing and continues, and it has its ups and downs, as all of you on this phone understand. Through all of this, I met Megan, and I learned about Mission Cure, and I became totally committed to working with her and all of you to help find a way to cure this disease. So I recently joined Mission Cure as its co-director. You see up there now, we have a couple of slides that highlight our new patient awareness, advocacy, and education programs. And in future webinars, we'll dive deeper into some of the specifics of those programs. But today, I just want to give you a little taste about our plans. As you know, new research, including the INSPIRE study that Dr. Uch talked about today, is leading to better understanding of the causes, contributors, and drivers of pancreatitis. But there is much work to be done to raise awareness of the disease and its impact on patients and their families. So first, we're hosting a pancreatitis patient webinar series. And yes, you were the first participants, and others are being planned. We plan to have a webinar approximately once a month from September to May with a break around the holidays. So stay tuned for more details about the webinar topics and dates. In between the webinars, we're also launching an educational blog series where you'll be able to log in at your convenience and read blog posts on a range of topics written by doctors, researchers, patients, some of NPF's young investigators, as well as the Mission Cure staff. Also, Mission Cure is in the process of designing a pancreatitis patient information and needs survey. We're working with other organizations and experts to craft the most comprehensive yet totally pancreatitis patient-focused survey. So you might say, why a survey? Well, everything we do at Mission Cure is 100% patient-focused, and we're working daily to progress one important goal: to accelerate breakthroughs that patients can feel in their everyday lives. And we won't stop until we find a cure. But with all of our passion and determination, we don't want to lose sight of the needs and priorities of patients, and we want to ensure that we always represent the voices of patients. So to that end, the survey will help us better understand your needs, wants, preferences, and priorities. But not only will the information help Mission Cure drive programs, but the data will also be anonymized and made available to other stakeholders to help them inform decision-making around treatment, care, research, education, and public policy. We are going to give you just a tiny taste of our survey today. So at the very end of this webinar, there will be just a few simple, literally just 4 short questions that are important to help us create the most useful webinars for you in the future. So please, please take just a minute to complete the short survey at the end of today's webinar. And when you see the link to the bigger Mission Cure survey, please take time to participate. This information is very important, as there is no single consolidated repository of pancreatitis patient data, and this will be a good first step. And we will link it to other data sources out there, such as the NPF patient registry and others. But we think that this will be a really good place to get a lot of patient input. Another project we're excited about is our pancreatitis patient emergency information cards. You've all seen similar cards, I'm sure, for other diseases or conditions such as diabetes, certain severe allergies, organ transplants, and certain drugs. Because pancreatitis is rare and many ER and hospital personnel have had little to no experience with the disease, as we all know, we hope that by providing a card with some of the key relevant information and guidelines about the disease itself, especially during an attack or flare, plus space for you to include specific information about your own situation and condition, will be helpful. We know having a card won't solve all the issues with misunderstandings about this complex disease, but it will be one tool in our toolbox that just might help. We're also developing Mission Cure's pancreatitis patient advocacy program to raise awareness of the disease and create a combined voice that gives patients an opportunity to share their stories and experiences and help drive and shape how we are seen and treated in the future. There are a lot of parts to advocacy, so stay tuned for more information. Well, I see we are out of time. So again, Thank you all for joining us today. It has been an honor and a privilege to be with you, and I hope you'll join us for future webinars. Again, the survey will be popping up in just a moment. Please answer these 4 short questions. And for more information about Mission Cure and our programs, please visit our website at mission-cure.org, or feel free to call, text, or email either Megan or myself. And I wish each of you and your children a happy, healthy, and pain-free day. Thank you so much.